Hello everyone, welcome back to my channel. I am Dr. Manjunath, a pediatrician and allergy specialist based in Bangalore. Today we will be looking into the newer frontiers in the management of asthma, and that is the remission in asthma. There is seldom any study, there is seldom any recommendation which spoke about remission in asthma as the primary management. We have always spoken control in asthma as the endpoint. Lately, many guidelines, including the China guidelines, ERS, ATS, BTS, YAKI, all of them have started recommending the remission in asthma as the end point in the management of asthma. Before we go into the details of it, make sure that you subscribe to my channel. Also, make sure that you like and share this channel as much as you can. When do you call remission in asthma? When you no longer have the symptoms, you no longer have the exacerbations, and you no longer are taking any medicines to control asthma. This is the typical understanding what remission in asthma is. We can be talking remission in asthma in its two flavors. One is a clinical remission, other one is the pathological remission, the clinico-pathological remission. As the name suggests, when you have no symptoms, no exacerbations, and no longer taking medicines, it is clinical remission. That means there is a possibility that the disease is still ongoing and the remodeling is still happening. And the clinico-pathological remission is when you no longer have the remodeling process going on. The disease has just halted, or it is no longer being a problem to that person. That is the final goal of any asthma management. So what it actually means is, in a person who already has a clinical remission, there is a possibility that the disease is ongoing. Despite the steroids, some of the phenotypes and the endotypes still go on to have the inflammation and the airway remodeling continuing to happen. They may remain quiet, but the storm can stir up the whole disease all over again. So the final endpoint, as we say, is the clinico-pathological remission, but many of them can never reach to that point. Ultimately, we are left with controlling of the symptoms and the remission as our endpoint. China guidelines have been quietly pushing the remission in asthma as the endpoint. Along with that, the European Respiratory Society and the American Thoracic Society had a consensus statement in 2023. No exacerbations requiring medicines, no missed or school, and stable, optimized pulmonary function tests based on at least 2 assessments in a year as the definition of remission in asthma. Somebody might argue, saying that all I want is the patient getting better. I don't want the term either control or cured or remission or whatever it is. How does it matter? Yeah, that's true. You don't want your patients to go bad. You don't want the disease to be posing any threat for that person. But the remission in asthma is a more ambitious goal with the advanced diagnostic tools, with the advanced therapeutic measures. Now we no longer just have the inhaled corticosteroids. We also have the biologics and immunotherapies, which are more precise, making your phenotype and endotype assessment, and then treating that person will just not keep the disease under check, but will almost cure a person. So this is a complete sea change, a change in the goalpost, and that is what is more needed for us. Well, do you have anything to measure if the person has gone for remission? Along with the symptoms, we also have some biomarkers to make sure that the person has gone for remission. One thing is the symptom score. You have to keep a good asthma diary, just making sure how the symptoms have evolved over days and months will tell us whether the patient has gone bad or better. So that's one thing. Another thing is your pulmonary function test. Increased fibrinogen or the thickening of the airway is directly proportional, or rather indirectly proportional, to your FEV1. With the increasing thickness of the fibrous tissue, the FEV1 is worsening with every possible year. So you will have to make sure if this person is going bad or better with the pulmonary function test. That is an important standpoint. Along with that, the marker of inflammation, what we have is FeNO. So that again will tell you if the person is getting better or not. Of course, there are some phenotypes where the FeNO is just not elevated. We will have to go by the symptoms and some biomarkers to tell us, may it be the basophil activation test, may it be the specific IgA to the total IgA proportions. So these ones will tell you if the person is getting better or worse. In every possible thing, what is more important is your symptom score. The symptom scores will tell you if you are getting better or not. Well, as a treating physician, what's your role? Your role is to identify which patients are likely to have the airway remodeling and continue to have the disease process, and identify those ones who can be benefited with the biologics and the immunotherapy. So that is something what as a asthma treating specialist you should be knowing. So with that understanding, you can direct him whether this person is just needing inhaled corticosteroids for the control of the symptoms, or if I start biologics, if I start immunotherapies, I will be able to bring that goalpost from control of symptoms to treatment to remission in asthma. So that is the primary understanding and the primary role of a physician